Good morning. I want to welcome everybody that's here in the room and also those that are joining us virtually to our Thursday morning grand rounds here at the UPMC Children's Hospital of Pittsburgh. If Dr. Dermody were here, he would tell you how he's broadcasting in beautiful, sunny Pittsburgh. It's not beautiful when it's dark outside, and it's a little bit cool this morning, but welcome. I have the pleasure this morning of introducing our speaker, who is Jim Squires. Most of you will know Jim. Jim earned his medical degree at the University of Texas, and he went on to complete his training in general pediatrics at Cincinnati Children's Hospital. After residency, he did two fellowships, both gastroenterology and then pediatric advanced / transplant hepatology. And he also completed a master's in clinical and translational research while at Cincinnati. After completing his training, he moved to Pittsburgh, where he joined the faculty in 2015. Jim, it seems like it's not been that long that you've been here, and we're delighted that you came. He currently is an associate professor of pediatrics. He's the director of the Advanced / Transplant Hepatology Fellowship, and he's the associate medical director of hepatology. He is a very skilled clinician and someone that I frequently will talk to when I have hepatology cases that I want to ask him about and that I fully enjoy working with in our care of the liver transplant patients. Jim is active both clinically and also in research pursuits. He is a co-investigator and site PI on several National Institutes of Health-funded consortium that focus on pediatric cholestatic liver disease as well as acute liver failure. He has leadership roles in several learning health systems that are committed to continuous improvement in pediatric liver disease and liver transplantation. And he has received funding from the Patient-Centered Outcomes Research Institute to advance this work. I was so excited when Jim agreed to give this talk on hepatitis C, a virus that is highly prevalent, but that we've seen the really miraculous development of a cure, a time, short-limited, couple months of therapy, and then the virus is gone. And I'm very excited to hear from Jim about hepatitis C virus today, how we find it, how we treat it, and what other lessons he wants to share with us to learn. So Jim, thanks very much for helping us all learn.
Thanks. Thank you, Mike. I was excited that Mike was going to introduce me today, so I wore my Mike Green vest. This is my one time a year that I get to wear it. So I appreciate the kind words. I appreciate the invitation. And hopefully we'll shed a little knowledge about hepatitis C today. Let's see here. So just disclosure, I do sit on a data safety monitoring board for Sanofi, which has nothing to do with hepatitis C, but those are my disclosures. So overview today, we're going to provide, or the objectives, we're going to provide an overview of hepatitis C virology as well as epidemiology. We'll discuss the natural history and presentation of pediatric hepatitis C virus, review screening and prevention guidance, and then finish up a little bit on some current and future treatment strategies as we work hopefully towards viral eradication. So, this was the kind of story that Mike was alluding to, right? This was really an unbelievable advancement in the care of liver disease. So, this was an unnamed virus back in 1986. It was non-A, non-B. It was first kind of identified in 1989. You can see there these blue boxes that kind of underscore the advances in biology. And, this discovery, led relatively quickly to, the evolution and understanding of the virology, which eventually led to these, development of what we're calling the direct-acting antivirals. This is the kind of salmon boxes, and these are the new medicines that are so highly effective. And it was critical how urgently needed these were because, this was a disease process that was the leading indication for liver transplant. It was a leading indication for hepatocellular development, and it was really devastating to the millions of people who were infected. And, I have vivid memories. I think, Simon will remember as well, going to some of the liver meetings when I was just, in training back in 2014 and 15, when they were presenting this work for the first time, and people were just blown away at how effective these were. And there was such an excitement about how this was going to really change the way that we practice medicine. Importantly and excitingly, our knowledge of HCV infection in children has similarly exploded. There's been testing of these drugs in the pediatric populations. This has been accompanied by updates in screening, diagnosis, management, guidance, and position papers from many government and health organizations. And all of this is towards this kind of goal set forth by the World Health Organization of a viral eradication by 2030. And this was a really aggressive goal, right? I mean, I think the WHO and others saw these medicines coming out, saw how effective they would be. They set this goal back in 2016, and we'll talk about some of the progress we've made to date in achieving that goal. Notably, these advancements were also recognized by other folks, importantly, the Nobel Prize Committee, who awarded the 2020 Nobel Prize in Medicine to the three physician scientists who discovered the virus. So what is the virus? What is the virology? So the hepatitis C virus genome, it's a 9.6 kilobase positive single-stranded RNA. There's a single open reading frame that encodes a 3011 amino acid residue polyprotein that undergoes proteolysis to yield 10 individual gene products. So these gene products encode material for the three structural proteins. This is the kind of E1 and E2 you see there on the outside, as well as the envelope glycoprotein that surrounds the RNA. And then there's 7 non-structural proteins. This is the P7, the NS2, NS3, NS4A, 5A, and or 4A, 4B, and 5A, 5B. And these, go on to participate in the post-translational and proteolytic processing and replication of the HCV genetic material. So when we talk about viral attachment, again, this initially involves those 2 envelope glycoproteins, the E1 and E2, which helps it attach to the outside of the hepatocyte. After attachment, the HCV enters into the cell via a clathrin-mediated endocytosis, which is followed by fusion between the viral and endosomal membranes. This leads to the RNA uncoding and release of the nucleocaspid into the cytoplasm. Uncoding of the viral nucleocaspid liberates the positive strand genomic RNA into the cytosol, where it serves as mRNA for synthesis of the hepatitis C virus polyproteins. So viral RNA is then replicated, processed, and packaged by various non-structural protein complexes, and eventually it then is released back out to propagate the ongoing infection. So it's a really intricate kind of viral life cycle. As far as epidemiology, so there are 6 distinct hepatitis C viral genotypes that have been identified. Notably, there is significant global variation. In adults, genotype 1 really constitutes most infections in the Western countries, including here in the United States. Genotype 3 is widely distributed in South Asia, type 4 in North Africa and the Middle East. You see type 5, which is kind of isolated down there in South Africa, and type 6 mostly in Asia. There's not a whole lot of data, but whenever it is reported, children who are infected appear to demonstrate kind of a regional distribution pattern that's similar to adults. And so again, in the US, most of the kids that we see are genotype 1, with type 2 and type 3 rounding out the next kind of main percentages. In the United States, there are state-specific rates of reported acute hepatitis C. Now, again, this is kind of acute hepatitis C versus chronic. And there is kind of variation of these infectious rates throughout the country. This is data from the CDC. This is from 2022, which is the most recent year that this data is available. And essentially what you can see is that states, with the highest rates of acute hepatitis C are in the east and the southern parts of the country, particularly in or near the kind of Appalachian region, which correlates with the ongoing opioid epidemic, which is obviously a huge risk factor for the spread of this virus. When looking at acute hepatitis C viral infections, again, starting in 2010, you kind of begin to see this rise in reported cases that really occurred across all age groups, greater than 20 years. I think excitingly, when you see some of the most recent trends since 2020 and beyond, there is some plateauing that we're beginning to see, also maybe even some decreases. And again, I think this reflects some of the efficacy of these direct-acting antivirals as they get out into the community. Still, I think it's really critically important to recognize that these current estimates are really that these acute cases that are being reported are probably really gross underestimates. And kind of current estimates are that in 2022, although there were 4,800 reported cases, this probably represents only about 7% of the total number of at least expected acute hepatitis C viruses. And so ultimately, the estimates really are that nearly 2.4 million Americans are living with hepatitis C, but probably only about half of us know that, well, I should say know that we have it. I don't have it, but only half of those who do have it know that they're infected. So when looking at chronic hepatitis C, again, as of 2022 or in the year 2022, there was close to 94,000 new cases of chronic hepatitis C that were reported. There was a higher number of newly reported cases among males versus females. That's the blue graph versus the orange graph. And this really occurred across all age groups. We see this kind of bimodal distribution in the 20 to 39-year-olds, and then a second peak around 55 to 70 years of age. Obviously, when looking specifically at kids, the reported data suggests that new cases in pediatrics are quite rare. But I think this is where, we tend to focus a little bit more in that, when you look at cases in young adults of childbearing age, it is notable that there's this peak, particularly as mother-to-child transmission is the most common way in which a child is infected with hepatitis C. So specifically, kind of looking into that, this figure shows the estimated prevalence of hepatitis C virus positivity among all adults, and that's the light purple bars, but then also breaks it down into hepatitis C estimated among pregnant women, which is the dark purple bars, and this is by state. You'll see Pennsylvania, which they promptly misspelled, is rated 10th on this graph, right? So it's near the top, with neighboring Ohio and West Virginia 6th and 1st. Respectively. So again, this is something that we generally consider still to be quite a big problem in our region. When looking at the geographic variation of birth rates of those infected by hepatitis C, again, this is really reflected in those bar graphs. And again, you kind of see this clustering in the Appalachian region of children at risk for being born to hepatitis C mothers. And again, this has increased over time. So again, between 2009 to 2018, in this JAMA paper from 2021, you see that the rates of mothers with hepatitis C doubled from 2009 to 2018. Notably, there are risk factors that are associated with this trend. These include race and ethnicity, with white race being associated with a higher odds ratio of being infected, not having a 4-year degree, and living in either a rural or a rural adjacent community. So, what's the natural history? What happens to a child when they're infected with hepatitis C virus? So I'm going to mainly focus again on those with the mother-to-child transmission, as this is the most common patient that we see in the clinic, and this is the most common way that a child is infected. So this is the pattern of kind of virological, clinic, and serological events that occur in a child that's infected perinatally with hepatitis C. So, generally what happens is following the perinatal acquisition, so that's time 0 there on the left, the serum alanine aminotransferase, or the ALT levels, begin to increase. This is the solid line. This indicates the kind of onset of clinical hepatitis. You see this kind of chronic undulating sawtooth pattern that emerges, which generally reflects ongoing infection, and is what we see when we measure ALT in these patients. Some of the maternal circulating antibodies, so that's the small dotted line, begins to decline in the first weeks of life. Generally with complete resolution between 18 and 24 months of age as maternal IgG kind of wanes in the child. This is kind of accompanied by a divergent appearance of the anti-hepatitis C viral antibody that's produced by the infant. That's the large dotted line there. This occurs shortly after infection. However, it's important to note that this is indistinguishable from the maternal antibody. So if you're just measuring antibody, you won't be able to tell if it's maternal antibody versus the infant's antibody, which is important when we talk about some of the screening practices later on. If you were to perform polymerase chain reaction, it is notable that you can detect the hepatitis C viral RNA within several weeks of exposure. Notably, this will persist, barring spontaneous viral clearance, which we'll talk about here in a second. Again, this is important when we think about how best to screen these patients, whether we're measuring antibody or RNA, and at what time points we do it. So we mentioned viral clearance. Again, viral clearance is the ability of a child or person to spontaneously kind of clear the virus and cure themselves on their own. Notably in children, this is quite a bit more common than occurs in adults. So anywhere between 25 and 40% of children that are perinatally infected do undergo viral clearance. I think that 40% is aggressive, but I think there are rates reported. This does usually recur in the first couple of years of life, although it can occur after that. And so in general, about 6 to 12% of patients with chronic hepatitis C beyond 2 years of life can still go on to clear the infection up to adulthood. Notably, there was kind of this one single case of reported recurrence of hepatitis C virus in a patient that was previously reported to have cleared it. Some have argued that they should use that as a reason to kind of continue to watch these patients. I think clinically, to direct practice based on a case report is probably not best practice. So when we see a child, if we see that they've cleared it, we generally consider that patient cleared and no longer need to follow them in the clinics. So what are some of the factors that are associated with this viral clearance? So one is being infected with genotype type 3. As a reminder, this is the genotype that's generally most widely distributed in South Asia and only represents about 10% of the infections here in the US. So it's pretty rare to have a type 3. Also, patients who have significantly increased ALT in the first couple of years of life seem to be able to clear the virus more effectively than others. And then having this host INFL3, which was formerly an IL-28B nucleotide polymorphism. This was a polymorphism that we used to test a lot because it was able to kind of predict response to therapy. And so it was important to know whether a child had this polymorphism. As we'll talk about in a little bit, now these therapies are effective independent of the polymorphism, so we don't really check this anymore. But there is data to suggest previously this associated with increased viral clearance. Some of these children do go on to have more severe disease than others. There are some associated factors that, again, kind of associate with that, obesity being one, survivors of childhood cancer, those with congenital anemias, whether you have HIV or HPV co-infection, ongoing kind of high-risk behaviors such as IV drug use or alcohol abuse, homelessness and incarceration. So again, these can predict someone who may have a more severe disease than somebody else. But in general, when looking at kind of the chronic hepatitis C clinical course for these kids, the liver disease is really, typically quite mild. Even in those who fail to clear the virus. Absent one of those risk factors, they generally do quite well. There are reported complications of advanced liver disease, things like portal hypertension, ascites, variceral bleeding, and again, that development of hepatocellular carcinoma. This is incredibly uncommon in pediatrics, even in those that we know have the virus that we hadn't been able to treat previously. Very rarely would you see these complications. And liver transplant is really almost never performed for this indication, at least in pediatrics. As noted, again, when you think about the clinical signs and symptoms, they reflect the mildness of the disease process in pediatrics. So again, most are asymptomatic. You wouldn't ever know that they have infection. As we already noted, the majority will have, kind of mild, persistent, and intermittent ALT elevations. There is really no correlation, though, between the degree of ALT elevation and histology when biopsies used to be done. About 10% of these patients are reported to have hepatomegaly, and some of the extrahepatic manifestations that, again, is mostly reported in the adult literature is really, really uncommon in pediatrics. As noted, we really don't do biopsies anymore in these kids. It's really rarely indicated. There was something called the PEDS C trial, which was performed in the early aughts, where these patients underwent biopsy as part of the research protocol. This had 121 patients that were enrolled in this study. As you can see, the majority, 42%, had really minimal inflammation. About 17% were categorized as mild, 38% as moderate, and only 3% with severe inflammation. There were 2 patients in that cohort that noted to have the development of cirrhosis. It's important to note that both of those patients were obese, and I think we know that cirrhosis can be seen in processes like metabolic dysfunction-associated steatotic liver disease, or NAFLD previously. And so it's hard to know whether the cirrhosis was related to the hepatitis C virus or not. Again, here's a representative picture for the pathologists in the room. Again, you have your core biopsy up top and a close-up there of the portal area. You have your kind of portal vein, which is that big open space. You see some bile ducts. There's an artery probably buried somewhere down in there. And essentially, again, the blue dots is the inflammation. And for the most part, this would probably be someone with a kind of mild to moderate inflammation on biopsy. So what about screening? I now want to move on to some of the screening practices for hepatitis C virus, because this has been an area where there really has been some a change that's occurred that I think has the potential to really impact how we treat and how we manage these patients. So the first question is who to screen. The recommendations have been kind of coming out fast and furious. So these were actually recommendations that came out in 2020 from the CDC virus as it relates to screening for hepatitis C virus. And at that time, there were two new recommendations that had come down. So one was to screen at least once in a lifetime for all adults greater than 18 years of age. And so this was actually an advancement from prior practice where screening was generally just in those 65 and older who had been at risk for maybe a blood transfusion before the virus was known and really screened for. They also suggested screening for all pregnant women, which again, I think is important when you think about pediatric HCV so that you recognize who those children are that would potentially be at risk for HCV infection. Still, these recommendations did not include screening at all for children. Although there was a concerted effort to advocate for screening, they didn't specifically come out with recommendations on screening for children. So then if you ask the question, well, then what children should we be screening? So we have NASPGHAN, it's the North American Society for Pediatric GI and Liver. We did put out this position paper back in 2020, where the recommendations really were that children suspected of having an HCV exposure, including those born to HCV positive mothers, should all be screened for hepatitis C virus. Then the question is, well, so how do we screen these patients if we're going to go to screen them? So again, this was the algorithm for 2020. And essentially what they suggested was that the initial screening test is for the HCV antibody. If that was negative, non-reactive, you didn't have it, didn't worry about it, moved them on. If it was positive, you then needed to go and do the confirmatory test, which is that HCV RNA, the nucleic acid test. Again, if that was negative, the patient didn't have hepatitis C. This likely reflected, again, in pediatrics, someone who might have gone on to have spontaneous viral clearance. If it was positive, they had hepatitis C, and then you link that patient to care. Again, important to note when going back to what that antibody looks like in kids, right? In those first 18 months of life, it is impossible to distinguish between maternal and child antibodies. So just screening for antibody in the first 18 months of life was not generally recommended. So we would have to wait and screen these kids at 18 months to 2 years of life so that we were sure if there was antibody that was there, that we knew that it was infant's antibody. We would then go on and do the confirmatory test and move on throughout the algorithm. So again, this screening approach was generally what was recommended by the American Academy of Pediatrics. It was recommended by the NASPGHAN Society, and this is generally how we practice medicine back in 2020. So how effective were we at doing that, right? The short answer is not very good, right? At least in children. This early report from 2020 demonstrates really some of the failures of these recommendations. And so in this cohort in Tennessee, 75% of patients in their experience never received HCV testing, despite the fact that they should have. In a more recent paper that was put out just recently in a cohort from Philadelphia, up to 79% of patients or exposed infants were inadequately tested for HCV. So we were not generally very good at catching those patients, testing them at 18 months of life. So, I think additionally, it was recognized that this kind of waiting for 18 months of life sometimes wasn't very palatable. It wasn't palatable to the parents. A lot of the physicians weren't very happy about it. There was really a lot of concern about, kind of being able to follow these patients up reliably. And so I think these two additional societies, so the Infectious Disease Society of America and the American Association for the Study of Liver Disease, they convened an HCV guidance panel that actually considered or recommended considering testing for the RNA at earlier time points, right? Because if you noted, or if you detect viral RNA, that's a positive infection regardless of when it's detected. So, this amongst kind of some of the other efforts that have looked at this led ultimately to these updated guidance recommendations from the CDC that were just published last year. And so, what these have changed, right, is that if you look at the picture on the left, that's the 2020 guidance. You do the antibody. If it's reactive, you do the PCR. If it's reactive, you have a diagnosis and you link that child to care. And you have to wait till 18 months in order to begin this algorithm. New recommendations are that we kind of throw that out the window, and we can now, in a child that we know has been exposed or is at risk of being exposed to hepatitis C, test that child at 2 to 6 months of age. You can go straight to the nucleic acid test for RNA. If it's positive, you have a child with hepatitis C, and you link that child to care. And so this has really kind of changed how we are thinking about managing these patients moving forward. Well, what about prevention, right? Are there ways to potentially prevent a child from getting hepatitis C infection? And it's important to note that although maternal to child transmission is the most common way that a child gets infected, it actually in and of itself is still a rare event, right? Only about 5 to 10% of patients born to hepatitis C mothers actually get hepatitis C, right? So there is a kind of a concerted effort to think about ways that we can prevent that, though. Preventing vertical transmission is a key focus, again, because this is the most common way in that children get infected. So some of the established risk factors include viremia, HIV co-infection, and maternal IV drug use. Some of the possible risk factors that have been reported include prenatal testing, prolonged rupture of membrane, and some OB procedures. So, kind of main strategies to decrease rates of transmission include decreasing viremia. And again, this is mainly with direct-acting antivirals and kind of curing the mother. Although it's important to note that antiviral therapy is currently not approved during pregnancy. And we'll talk a little bit that in a little bit. So, in theory, this should be done kind of before conception. Again, one may want to avoid invasive procedures where possible, but we recognize sometimes this isn't always possible. And while drug and abstinence programs and kind of safe drug use programs have been trialed, there really is kind of lacking good data to support kind of full benefit of these measures. I want to call out some of the work from Catherine Chappell, who's here at UPMC, who has done really exciting work in this space as it relates to treatment of mothers with hepatitis C. So this was a phase 1 pharmacokinetic study where they used some of these direct-acting antivirals and treated pregnant women. And so this figure essentially shows what happens, right? You had 9 women in this study. You treated them with the direct-acting antivirals. You see their HCV loads there on the left, and they dropped to 0 and non-detectable. SVR12 there at the bottom, that's kind of a key output. That stands for sustained viral response at 12 weeks, right? So that's really the test of cure. So after 12 weeks, after you finish your therapy, you do an HCV PCR. If it's negative, you've cured them. And so all of the women essentially achieved SVR12. They did report some of the safety data in this paper as well. There were no major malformations reported in the children. There was no issues at birth. Through the first year of life, and none of the children, at least in this study, had HCV transmitted to them. In a second kind of prospective observational study that came out of India last year, they treated 26 women in the first trimester. Again, being in India, genotype type 3 was the most common in this cohort. Again, all women achieved 100% SVR12. There were no significant birth defects noted, and again, no children had HCV RNA at 6 months of life. Again, important to recognize that these very small studies really need to be recapitulated at a much bigger level. Given that kind of small rate of transmission of 5 to 10% of kids, I think it's still kind of to be determined whether treating the mother does actually prevent mother-to-child transmission at birth. So there are some pros and cons to thinking about treating with direct-acting antivirals during pregnancy. Obviously, some of the pros, maternal cure while engaged in pregnancy care, right? We know that pregnancy is a time where women are more likely to be seeing their doctors regularly, so they have more touch points with the healthcare community, more opportunities to treat. Again, this possible decrease in mother-to-child transmission, although that needs to be fleshed out a little bit more in larger studies. Again, the fact that usually when women are pregnant, they may have increased insurance coverage that they wouldn't otherwise have, and so more access to care. Obviously, if you were to treat a woman who is infected with hepatitis C, you then are able to decrease the community transmission and potentially decrease some of the kind of reported HCV-associated adverse outcomes that have been reported in women infected with hepatitis C. Some of the cons, again, human safety in pregnancy is not well established, although these small studies are being done and there are ongoing clinical trials that are looking to answer this question. Safety of breastfeeding has not been established with these medicines. And again, these are 12-week treatment courses. And so it is possible that a woman would kind of bridge through birth and then be faced with whether or not it's safe to breastfeed their child. As we'll talk about in a little bit, as there's more and more established data for the efficacy of treatment prior to pregnancy and treating the kids, some may wonder why even kind of go through this and kind of treat this vulnerable population if you can treat the mother afterwards and you can treat the kid afterwards and everyone's going to be fine. Again, there's difficulty in accessing DAA therapy prior to delivery, although I think this is a barrier that's kind of decreasing that we'll talk about in a little bit, as is cost effectiveness. Not established specifically in this population, but we'll talk about cost effectiveness in a little bit and show that really treating is cost effective. I do want to touch a little bit just about horizontal transmission. So this is where the virus is spread from person to person, not mother to child. This is the most common way that the virus is spread, generally, again, among adults. And so it's important. But when thinking about horizontal transmission, or at least in counseling our patients with a child who may have a hepatitis C virus, we really kind of stress the fact that hepatitis C is not transmitted by casual contact. So there really is not a risk to other children in the home. There are no restrictions that you need to put on these kids at school or in sports. It is important to recognize that families do not need to disclose this. This isn't a reportable condition that they need to tell their school or their daycares about. And a lot of reasons that families don't want to do this is because of things like discrimination and stigmatization, which still exists, right? Coughing, sneezing doesn't do it. You can share food and drink, you can hug, you can kiss, you can do all those things. I do want to focus just a little bit on stigmatization, because I think this is actually something that I tend to focus on with my patients in the clinic, because I think it's important to try to eliminate the stigma that exists around hepatitis C. This was a picture that was drawn by a teenager that had hepatitis C that was being treated over in England at the NHS. And you can see, words like guilt, fatigue, desolation, shame, fear, confusion, right? This is something that these families do feel when they have this, kind of virus infection. And I think it's something that we can work to kind of overcome, right? We have to recognize that stigma exists, right? We do have to respect the privacy and the right for non-disclosure, but I really try to encourage my families, well, this is a virus. This is a virus like any other virus. And so, they shouldn't necessarily be embarrassed or have this stigma attached, but, we still need to recognize its existence. And there are campaigns like those used in HIV that have really worked to kind of decrease stigma elsewhere. And so I think this is something where we still have some work to do, because I think this is still potentially one of the barriers to access to care that exists among patients who are infected. Still, back to horizontal transmission, it's important to recognize, to kind of advocate for universal precautions at school and at home. You really should be doing this anyway, irrespective of an HCV infection. You do want to avoid blood exposure, so we do kind of counsel against, in the older kids, sharing razors, toothbrushes, nail clippers, things like that. And if there is a blood exposure, make sure you use gloves and some dilute bleach to clean up any spills. When you look at kind of modes of horizontal transmission, it's important to recognize that this, again, still does occur and is the most common way that this virus is spread throughout the community. Specifically, some of the modes that it is transmitted with are through things like unsafe injections, sex and unclean piercings. So, these are kind of three common modes. And so, again, for our specific population, it's really important to recognize that, our adolescents are at high risk. And so we have to kind of make sure that we counsel about this. And again, when I'm seeing a patient and when I'm thinking about treating them, I really want to make sure that I'm able to treat this patient before they're an adolescent and start making adolescent decisions. So what about treatment? How do we do that, right? So again, this is a graph that shows the evolution of HCV therapy since the early 90s. You can see, in the early 90s, it was terrible. You used interferon, which is a terrible drug with terrible side effects. It had a terrible response rate. And so, treatment was really dismal back then. And over time, this has been amended and augmented and modified to where ultimately in the early and mid-teens, we have the development of now kind of interferon-free, direct-acting antivirals that reach cure rates of near 97 to 99%. So really an unbelievable achievement. And so this is, again, has changed the way we practice medicine. So in pediatrics, given that initial poor response rate, the terrible side effects of interferon, it used to be that in children, we would really only treat if you saw, significantly elevated liver enzymes, with the kind of presence of evidence of liver dysfunction. If you did a biopsy and you saw significant fibrosis, you would maybe consider treatment. Or if there was a personal or family history of early cirrhosis or hepatocellular carcinoma. Now, you just got to be 3, you got to have the virus, and we can treat you, right? It's as simple as that. When looking at kind of mechanisms and different classes of direct-acting antivirals and going back to the kind of HCV life cycle and where they interact, they essentially, kind of impact almost every stage of the life cycle, from translation to processing to replication to assembly. And there are different classes that we'll kind of focus on here in just a second. So if we go back to our virus and its subunits, you see that the various classes of drugs that have been developed kind of target different non-structural proteins, including the NS5A inhibitors. So these all end in aspir, so you know which ones are the 5A inhibitors. You have the NS5B inhibitors, which all end in buvir. And then you have the protease inhibitors that all end in previr. So when you kind of are reading the reports, you can kind of recognize which combination of drugs are being used. So this is a table that we published in that 2020 position paper from NASPGHAN, and this just highlights kind of really some of the work in pediatrics and some of the combinations that were available at that time. And you can see that most of the regimens use a combination of DAAs targeting different aspects of the viral life cycle. You can see that the regimens, again, are now approved for kids down to as young as age 3, which is very exciting. You can see that the regimens really target all genotypes. So 5 and 6 weren't included here, but those studies have since been done. And so now we do have kind of pan-genotypic coverage for this. And these are incredibly effective, right? The only studies where 100% SVR12 was not achieved was when a patient dropped out and didn't complete the study, or in the youngest, populations in the 3-year-olds who were 3 and didn't want to take a medicine. Really incredible cure rates for this. So most recently, you have the improvement of kind of pan-genotypic direct-acting antivirals that target genotypes 1 through 6. These have now been approved in kids. So you've got Mavyret, which is a combination of NS5A and a protease inhibitor, and you've got Epclusa, which is an NS5A and an NS5B inhibitor. So we've nailed it, right? We've achieved our goal. We are at the jackpot, right? We are at the point where we have this promise of a once daily, patient-tailored single pill with a treatment rate of greater than 95% with minimal side effects, and this is now available for all kids, right? So what's going on? What are the barriers? Why haven't we then achieved a more effective response to this? So this is maybe an abbreviated list of some of the barriers. So cost, medical restrictions, paperwork and appeals, adherence and palatability, and access still remain issues. So we'll talk about a few of these. So cost is one. This is still a very, very expensive medicine. So we're talking $26,000 to $75,000 for a treatment course. This is still upwards of $1,000 per pill. And so this is a huge barrier, and one that previously was a significant thing that got in the way of treatment. But this has really been debunked, right? There's been lots of these that come out. This one just came out in May of this year, looking at cost effectiveness. And so this study was really exciting because it went down to age 3. And it said, what is the cost effectiveness of treating our youngest population? And essentially, it shows that treating 3-year-olds with perinatally acquired HCV was projected to increase life expectancy and decrease healthcare costs. This happened across the board. And so, the bottom line here is, the earlier you can get patients treated, the more cost effective it's going to be. So cost is really something that we shouldn't necessarily have to worry about anymore. What about medical restriction? An analysis back in 2017 kind of went and graded Medicaid programs, and they found that 50% of programs received a D or an F for severely restricting access to these medications. Why were these being restricted? Well, some states had prior authorization needs. Some had fibrosis restrictions. So if there's the presence of fibrosis, you weren't able to treat. Some had substance use restriction or retreatment restrictions, and some had sobriety restrictions, right? So there was a lot of kind of social barriers that were put up to treat this, because again, insurance companies were worried if you treated somebody that was actively using drugs and you spent all this money treating them, they would just get reinfected. You'd have to do it again. Luckily, this has really kind of gone away. So, over the last several years, most states now have a grade of B or better. Pennsylvania, you'll see, is rated there as an A+, where essentially none of these restrictions exist anymore. And I think we have seen this clinically in practice, where it used to be, kind of a bigger deal to go and get these kids treated when we saw them in clinic. And nowadays, I have not heard any issues from our nurses or prior auth specialists getting these approved. So, still, even with the current updating screening algorithms and the loosening of these restrictions, all the algorithms end in linkage to care, right? So we identify these patients, great. We still got to get them into an office and get them access to these medications. And I like this quote because I think it really sums it up nicely, right? So, the independent development of curative DAA therapies and improvements in identifying patients infected with HCV will actually do little to stem the tide of inevitable morbidity and mortality unless the two efforts are linked by improved patient access to experienced, accessible medical care, right? That is critical, right? You can identify all the patients you want, but if you can't link them to those that can actually provide the care, it's not going to do any good. And so this recent MMWR report really underscores some of the gaps in linkage to care that have prohibited achieving significant progress towards viral eradication. Because when they looked at the data of approximately 1.7 million persons with evidence of HCV infection, only a third had been treated, right? So we're not getting to the patients who are infected, and we know that. And this is kind of spilling out into the lay press, right? Here's just a few examples from CBS News. Hepatitis C is treatable, but still claiming lives. From NPR, hepatitis C can be cured. Why aren't more people getting treatment? I think locally at the Trib and the Post-Gazette, right, we're grappling with untreated hepatitis C. Just a third of PA patients seek treatment. What are the barriers? And this one specifically to kids from Kentucky, where a serious liver ailment is stalking Kentucky children. It's very scary, but they aren't getting a cure, right? So this is still continues to be a significant problem. So what are the next steps? How are we going to begin to address this access to care and make sure that our patients are able to get these medicines in order to begin treatment? So I want to specifically call out Dr. Anne-Marie Rick. Anne-Marie has been a great partner to work with. Many of you, or some of you may know her. She's a physician scientist here at Children's. She does research and her clinical interests are related to perinatal hepatitis C infection. So I was lucky enough to collaborate with Anne-Marie and her team. We were able to secure some seed money from this DXQI, which is funded through the Society to Improve Diagnosis in Medicine. We used this money to begin, again, collaborations with UPMC, with the Allegheny Health Department, and with the Allegheny Health Network, ultimately with the goal locally to improve screening of children at risk for vertical transmission of hepatitis C, to enhance diagnosis, linkage to care, and ultimately cure chronic hepatitis C beginning in our region. And so this is an example of some of the output from some of this work, that's been implemented. So this is a map that shows all patients from UPMC Children's Primary Care Center and the Children's Community of Practice, or the CCP sites. This is all children born October 2020 or after, with a documented exposure of HCV in the medical record. And that's either on the problem list or at a visit diagnosis. The size of the circles are proportional to the number of exposed patients, based on zip code. And so you can see, there's 931 patients that have been identified here, and you can kind of see where they are in the community and at what volume they are. So, we're kind of trying to develop strategies to recognize where these patients are. And then you can imagine a program like this being rolled out here locally to help reach these patients. So this is a program called CAMP. This was led by one of my mentors back in Cincinnati, a man named Bill Balistreri. CAMP stands for the Kentucky Hepatitis Academic Mentorship Program. So this is a kind of a tele-mentorship, peer-based training program that's really designed for primary care physicians to get mentorship from subspecialists that are located in the big cities and be able to link that knowledge locally to where the patients are, right? And so the goal of CAMP is to improve the health of individuals in underserved communities throughout the Appalachian region, again, there in Kentucky, by building a primary care workforce trained by experts to screen, diagnose, treat, and follow persons infected with hepatitis C, right? It's getting the knowledge out into those that are seeing these patients on the front lines. And you can imagine, again, something like this paired with some of the work we're doing here to recognize where patients are could really begin to bridge some of those gaps. This is another effort that I'm kind of excited about. So this is a company called Cepheid. And again, Anne-Marie and I are kind of working with this company to try to figure out how we can maybe test some of this. So they've actually developed this technology. It's now been FDA approved in adults, right? So if you think about it, right, if you're going to test a child for or anybody for hepatitis C viral RNA, that requires a blood stick, right? So even if you see them in the clinics, you still got to send them to the lab. They got to get the blood drawn. They got to get the test. And that's just another opportunity to kind of lose follow-up, right? Patients leave like, I don't want to do it. I don't have time. Maybe that stigmatization is preventing them from going and getting tested. So again, they kind of slip through the cracks. Many of the primary care folks may recognize Cepheid. They actually have technologies for point of care for RSV and flu that are already in many of the pediatric offices here. And they have developed essentially a point of care HCV RNA test that in the adults just requires a finger prick. So you do a finger prick, you fill up this blood cartridge, you put it into that cartridge, you run it by the machine, and in less than an hour, you have a positive or negative test, right? This has not been approved for in kids. It hasn't been tested for in kids. And so we're actually in conversations with the company to try to figure out, is there a way to maybe do some trials in our offices on children, again, where maybe you could do a heel stick and be able to test for the hepatitis C actually in the office. Obviously, then if the patient were to turn positive, you can link them to the hepatology clinic. Again, we still can't treat these kids until they're 3, right? The medicines have not been approved but below age 3, and they won't be. So I think that there's still going to have to have a process in place to follow these kids and make sure that they're getting treated when appropriate. But again, I think recognizing them early and linking them to that care is kind of a critical gap that I think we can continue to work on. I also want to kind of just specifically focus that the government has gotten behind this, right? So the Biden administration in their most recent budget, put out $11.3 billion that would go towards treatment, testing, and education, right? So this is out there, this is written, this is ready. This is a paper from Science that kind of highlighted this, right? 11.3 is a big price tag, right? So a lot of people worry about that. And so that's one of the reasons why this hasn't been fully approved yet. Luckily, we have a congressional budget office, which actually has recently scored this proposal. And essentially what they found is that in their estimates, this initiative would prevent 24,000 deaths over the next decade, and it would save $18.1 billion, right? So cost positive, right? This would save over a decade $6 billion in medical costs if we were to approve this and get it rolled out. So what's going on? This is a New York Times article from this past April, right? And you can see that this initiative is languishing because Congress approves the budget, right? We got a broken Congress and it's not approved this budget yet. So although this thing has been written now for well over a year, as many of you may know from the news, we get these continuing resolutions without kind of a full, supported, budget for the government. And so we have not been able to kind of access this money that's been budgeted and put aside. So in my kind of final slide, I would just advocate that there is an election coming up for those who may not know. Here in Pennsylvania, you still have time to register. So there's the link there. We have till the 21st to kind of register to vote. And on the 5th of November, you can go out and vote. You can look at your congressman's kind of profile. You can see whether or not they support this initiative or not. And I think your voice does matter and can be beneficial to the kids in our region. So in conclusion, hepatitis C remains a significant cause of morbidity and mortality worldwide. There has been a dramatic increase in newborns at risk for HCV exposure. And again, this has been led, at least locally, by the ongoing opioid epidemic. The careful description of the molecular virology of hepatitis C virus has led to highly effective direct-acting antivirals that can essentially cure this disease. Still, improved screening and linkage to care will be needed to ensure that every child has equitable access to proven, effective, and safe therapies. I think that's it for me. I am happy to take questions or